Okay. Guys, this is Dr. Reiter from ENT, and he is here to talk to us about head and neck tumors and surgery. So thank you very much, and he brought us lunch. So thank you.
Thank you.
So we as a department are very excited about this, and some of that comes to the fact that everything that we've heard from the providers in neurosurgery has been like rave reviews about this unit, so we're really excited to get our folks here. And then the other issue is trying to centralize things, because our patients are a little bit scattered at times. So the more we get, people in one unit where staff is familiar with them and staff is familiar with us and such. To that end, I think on May 9 Central, we've almost had a little bit of an issue because we've been very resident driven as far as our inpatient service, and not that that's completely going away. I mean, residents aren't always available, and our guys are in OR, they're in clinic, and that sort of thing. So over the last year, we've gotten a PA that we're trying to make sort of our point person. So she'll be kind of hopefully the one that you'll have easier access to, so that there would always be somebody to respond and such. So just a little bit about me. I came here in '98, fresh out of residency. And now as our specialty has grown and our department has grown, we've got a lot more people like Dr. Moore and Dr. Schumann that you've met who have subspecialty training. So again, I came directly out of residency, and over the years have pretty much done all aspects of ENT, and that's narrowed down a bit, by desire and practice, that most of my practice is head and neck cancer. I still do a fair amount, I'll just say of general ENT, which is the nasal and sinus work and sleep apnea. Dr. Moore does most of the laryngology kind of stuff. And then we've got pediatric folks. Dr. Lee does the cosmetic and reconstructive plastics. Dr. Coelho, he hasn't come up then. Okay, so Dr. Coelho doing ear surgery. So I was going to focus on this because it's a vast majority of our inpatients are head and neck cancer related. So we use the term generally in terms of head and neck cancer, but most of the time when we talk about head and neck cancer, we're talking about the, as we'd like to say, the upper aerodigestive tract, so mucosal surfaces of the pharynx, the larynx, oral cavity, oropharynx. We also do a number of other things, skin cancers in the head and neck area, thyroid and parathyroid and salivary glands, among others, and then benign and malignant disease. So then just some basics. Head and neck cancer is kind of a small subset of cancers, so usually is like don't want to use the term, but the cast aside stepchild of cancer in some cases. And the other issue is, historically, a lot of our patients, based on risk factors, have been not as educated, not as politically active, so there hasn't always been a lot of focus on head and neck cancer and getting resources and everything. Just as far as sites, oral cavity, larynx more so than pharynx, and then nasal cavity. So one interesting thing that we see, historically our main risk factors have been tobacco and alcohol abuse. Lately that's been changing more and more. We're seeing more non-smokers, non-drinkers with tumors caused by the human papillomavirus, and that's actually good and bad. It's led to an increase in tumors in people who don't have otherwise known risk factors, but on the other hand, they tend to be much more successfully treated cancers. So kind of makes us look good that our 5-year survivals have gone up a little bit, but that's mainly because the tumors caused by the virus respond very well to treatment. And then again, just the risk factors, some occupational exposures, sinus cancers we see in people with a lot of wood dust exposure, different metals and fumes, that sort of thing. Poor oral hygiene, we can't say anything specific about that, but we have lots of people who have bad teeth, maybe rubbing against tongue and other cheek, that wind up getting cancers. So the symptoms, more often than not, someone will have, pain somewhere, whether it's in the mouth and in the throat, that sort of thing. Sometimes, and especially the HPV-associated tumors, they can be surprisingly asymptomatic tumors in the pharynx or in the tonsil or such, and they just come in with a neck mass. But then also, depending on where it is, larynx, voice change, pharynx, potentially swallowing problems, and weight losses in a lot of cancers. So then our three main arms of treatment, as with a lot of cancers: surgery, radiation, and chemotherapy. In a lot of patients, especially if it's more advanced, they may get all three. And then palliative care figures in quite a bit, depending on the stage of disease. And then we work with a variety of other practitioners as far as optimizing the patient outcome. So when do we operate? So it's not a type of cancer where every single patient gets operated on. With more early stage disease, as odd as it sounds, sometimes surgery has a much better long-term morbidity profile than if someone gets a full course of radiation. And studies looking at it, actually surgery can be less expensive than 6 weeks of radiation. So benign or radiation-resistant tumors, people who decline. And then again, in more advanced stage disease, that's when we usually plan to use multimodality treatment. And for a lot of advanced head and neck cancers, it's oftentimes surgery with radiation and even radiation and chemo afterwards, or we try what's historically been called an organ preservation approach. They get chemotherapy and radiation up front to see if that alone suffices. That really got popular in the 80s to 90s with laryngeal cancer. That's why we call it organ preservation, talking about the larynx as an organ. So, obviously going through life after your larynx is removed is a big lifestyle change. So if we can preserve the organ, then we do that. And then in some cases, functional considerations mean we want to save, for instance, to use that example again, the larynx as an organ, if it works. So someone who comes in and their larynx has already been damaged by the cancer, so they need a trach and they can't swallow and they need a feeding tube and they're not speaking very well, we're not really helping them all that much by giving them chemo and radiation, which may have a little bit of a lower likelihood of getting rid of the cancer by doing it that way. So yes, you still have your larynx, but it doesn't really work anyway. And then in some of our patients, obviously they can have chemo and radiation and cancer doesn't go away, or it comes back a few years later. And then in some of our patients, especially in the larynx, the cartilages and the voice box really don't hold up well to radiation and chemo in some cases, so they may come back in and the cartilage is infected or the larynx is collapsed down because the cartilage is damaged. So even without an active cancer, they may end up needing surgery for those reasons. So then a variety of different ways that we operate. Big, if you will, open surgery, transoral robotic surgery, which our other partner, Dr. Candle, does, the transoral robotic surgery, or TORS. Endoscopic surgery we do maybe on some earlier tumors in the larynx and pharynx, something we can get out through an endoscope, or obviously, as Dr. Schumann spoke to you about, removing skull-based tumors, sometimes in conjunction with the neuro folks. So sometimes that's done for sinus tumors. And then the deciding factors, obviously we need to do what we need to do to get the tumor out, but if we can save morbidity, shorten the hospital stay and such, that less invasive means like endoscopic resections and TORS comes into play. So one source of amusement and ire in our specialty is that in a lot of medical floors and even the internal medicine folks, every time we touch a patient with a surgical instrument, they say the patient had radical neck surgery. So a radical neck is a very specific surgery, and that just refers to removing the lymph nodes from the neck. The radical neck procedure entailed also, removing the lymph nodes, removing the internal jugular vein because most of the lymph nodes follow the jugular vein, removing the sternocleidomastoid muscle because the lymph nodes are right under that, and then also removing the spinal accessory nerve, which goes down to the trapezius because a number of lymph nodes follow that. So that was kind of the way it was thought initially, that what you have to do in order to get out all the lymph nodes. And then throughout the last century now, time flies, people realized, you can get lymph nodes out and save those structures. So that brought in things that we call modified neck dissections, where we save either the jugular vein, the sternocleidomastoid muscle, or the spinal accessory nerve. With neck dissections as a group, we also talk about the reason for the neck dissection. So if someone comes in and they have, say, an early cancer in their tongue, and by x-rays or by exam, we don't see or feel any lymph nodes in the neck, we'll sometimes remove those lymph nodes, and that's what's called an elective neck dissection, if the risk of having microscopic spread to those lymph nodes is high. So that depends on how big the tumor is or how deep it is. So in general, if the risk is in the neighborhood of 10 to 20%, we would do an elective neck dissection. And then a therapeutic neck dissection is if we're going in, someone has lymph nodes. And then lastly, a selective neck dissection is oftentimes done with or as an elective neck dissection. And the goal there is really just to remove the primary area of lymph nodes that might be involved by a cancer in a particular area. So for instance, an oral tumor is most likely to spread to lymph nodes from the upper neck, so we do a selective neck dissection just removing those. If someone has a skin cancer on the back of the scalp, it's most likely to spread to lymph nodes on the back and side of the neck, so we just remove lymph nodes there. So we're selecting the areas of the neck that we're going to be removing lymph nodes. You guys can feel free to ask questions along the way. I do have this tendency to talk fast, and as I realize, I've got a clinic at 1, but I've got tons of time. And then this just goes through, I mean, some of that rationale. I mean, different areas in the head and neck will characteristically spread to lymph nodes in a certain area. So those are the lymph nodes we would go after in an elective neck dissection. So if someone has a laryngeal cancer and we don't feel any lymph nodes, we're usually just removing the lymph nodes from the jugular chain here just on the side of the neck. Whereas if it's oral cavity, as I said before, we're focusing more on the lymph nodes in the upper part of the neck. And the same thing really holds for infections. So if someone has a bad tonsillitis, and you see this more in kids than in adults, but when they get a pussed out lymph node, the location of the pussed out lymph node is oftentimes going to tell us where the infection started if that's otherwise not apparent. All right, so then these are the gory pictures. So anyone who's like eating just to prepare, there's nothing really horrible, but just so that you guys get a handle on things, because sometimes you see an incision, you don't really know what went on to get to that point. But unfortunately, although people are playing around with endoscopic surgery, I mean, the common way to do any kind of a neck dissection is a rather large incision. We're lifting most of the skin up off the neck. So this just shows kind of our normal anatomy, the sternocleidomastoid muscle. The jaw is way up here, and then that's the submandibular gland. So in a radical neck, again, virtually everything is removed. So this you can just barely make out here. I mean, that's the carotid artery still there, but the jugular has been removed. The sternocleidomastoid has been removed. The only thing that is still here, this is the spinal accessory nerve, so you would actually say that's a modified neck dissection, but it looks about the same as a radical neck dissection. And then you can see the submandibular gland, so the salivary gland has been removed as well, because there are usually a half dozen or so lymph nodes up in that area, so removing the gland allows you to better clean out all the lymph nodes there. So then I've tried to include just very simple, basic kind of post-op stuff. It's not that common that we're just doing a neck dissection. More often than not, I mean, if someone comes in with an early stage tumor, as I said before, we'd be removing the tumor, so maybe part of their tongue would be removed, and they'd have a neck dissection. So obviously, whatever primary tumor was addressed would bring up other post-op concerns. But just for the neck dissection, I mean, we put in 1 or 2 drains. The pain isn't horrendous, but especially if it's a modified or a selective neck dissection, we're pulling up on the sternocleidomastoid muscle because all the nodes are underneath it. So we're pulling up on the muscle throughout the whole procedure, which is a main source of pain there. We're still a little bit hesitant, even though there's more and more data, and we're all going away from opioids and such, but more and more data to say, well, we can safely give anti-inflammatories. Most of us still don't really like to do that all that much, but I was just looking at a couple studies yesterday showing using anti-inflammatories doesn't necessarily increase your risk of bleeding. So between that, we've also started a little bit more so using gabapentin, and Dr. Lee and Dr. Candle actually had a little sort of study protocol going with anesthesia using ketamine infusions, at least in the unit, I believe, on their flap patients, and have shown pretty good results that too can lessen opioid use. And then the post-op stay, again, for just the neck dissection, it's a little bit unusual, but a day or two, they're really not that restricted in what they can do and should be doing. I mean, it's light activity and everything. In some cases, depending on home situation, distance traveled, I mean, we may keep them an extra day or so to see if we can get the drain out before we send them home, that sort of thing. But, commonly we do send people home with drains if the right situation exists. Any specific questions? Yeah. So then what are different things that can go wrong? Well, really related to the fact that there's many nerves in and around the neck. So, I mean, you can have vagal nerve injury and have hoarseness. The spinal accessory nerve can give you shoulder weakness, tongue numbness or weakness. I always like Sylvester Stallone's picture just because one of the, unfortunately, more commonly injured nerves during a neck dissection is what's called the marginal mandibular nerve, or branch of the facial nerve, which comes kind of right underneath the jaw here. So as we're lifting up the skin and working on that submandibular gland area, sometimes that nerve gets stretched or even permanently damaged. And people have this little bit of weakness. The nerve goes to a muscle that pulls down the corner of the mouth. So Sylvester Stallone, the story that I had heard is he was like a forceps delivery during birth, and when the baby's head is grabbed, sometimes the nerve gets crushed in that regard. So, does anybody watch This Is Us as well?
Yes.
Like, what's his name? Vilo Ventimiglia? He's got the same thing. He's got, so I don't know what his story is, but anyway. And the phrenic nerve is in the area. I mean, that's deep to where the lymph nodes are, but rarely, depending on where the tumor is or such, people can have diaphragmatic weakness, which can be a big issue. The brachial plexus is also very deep in the deeper muscles of the neck, so I mean that's almost unheard of that gets injured, but it is at risk. And then kyleak is kind of a big one. Yeah, so I mean the thoracic duct in particular on the left side can go up pretty high in the neck. So our teaching is when we're removing lymph nodes, and we're not going in and removing the individual lymph nodes. The lymph nodes are encased in the fatty tissue in the neck, so we remove all of that fat with the lymph nodes. So as we're removing tissue in the lower part of the neck, we generally try and use clips or ties and such so that if we are going across the thoracic duct, it gets ligated. But inevitably, despite how we try, in some cases you can have a kyleak. And chyle, if you've ever seen it, it's very different than your normal serous drainage into a drain. When someone's on a more normal diet, the fat comes out in that, and it literally looks like milk. I had a patient, he had a serum, anyway. I had a patient recently who we're still dealing with. It's not very big, but has a little chyle leak, and it's literally like drawing milk out. So the treatment for that, I mean, if it's big and a lot is coming out of it, that sometimes is something we take them back to the operating room and try and ligate. Sometimes we'll try and move a muscle flap into the area where it looks like the drainage is if we can't control it otherwise. Our IR folks are like really impressive, and I didn't realize they could even do this until we had to call on them. But they can actually embolize the thoracic duct, and they sneak a catheter into the abdomen somewhere and get into the lymphatic ducts and go all the way up into the neck and can block it off that way. And then rarely we have thoracic surgery go into the chest and ligate it that way.
Oh.
But in most cases, if it's a lower output, we may, if the drain is draining it, then fine, and then we'll just try and put a pressure dressing on to see if that will get the tissue to seal off. If there isn't a drain there, sometimes then we'll have to aspirate and put a pressure dressing on. But something that we have to look for. And then skin flap necrosis, I mean, I showed in the previous slide how we're lifting all the skin up off the side of the neck. Well, those are somewhat long flaps. Now, in general, most people, if they haven't had surgery, haven't had radiation, that's not really a big concern. Where it comes up is some of our patients who've had radiation. The radiation has already damaged the circulation to the skin. In some cases, the skin may be very thin, in particular if the tumor mass had stretched it out or so. So in cases where, we're making a big incision and we're concerned that the skin may not heal, well, if we've done a radical neck, you've got nothing between the skin and your carotid artery. So we worry a lot about carotid exposure and carotid blowout, which can be a life-ending spectacle on the floor. So in those cases, sometimes I've had two even in the last month. We may use some kind of a muscle flap, like even a pectoralis flap, in order to cover over the vessels to protect that. So then oral cavity and oropharynx, I'm not going to dwell on that a bit, but I mean, just oral cavity is essentially back to the anterior pillars of the front of the tonsils, and the oropharynx is what you see behind. Some different approaches. Transoral is kind of what we do whenever we can, and I mentioned before, like a small tongue tumor or so, we can oftentimes get in through the mouth. Sometimes we're limited if, by degree of jaw opening, by presence or absence of teeth can make things easier or harder. But that's kind of a simple way to do things if it's a smaller tumor and accessible to that approach. So this is just very simply, how we do a tonsillectomy, but in some cases, if we've got a very small tumor within the tonsil, we basically use this exact approach. So when we take out a tonsil in someone who has like sleep apnea or chronic tonsillitis, we basically dissect the tonsil up from the muscle underneath, and it's the tonsillar pillar muscles here. If we're taking out a cancer and we want to try and get a margin, then we'll take a lot more tissue and even take the underlying muscle so we can see if we can get everything out. But that, in a lot of cases, is easy enough to do with just a headlight and looking in. Bigger tumors in the tonsil and going further down may require transoral robotic surgery or